The dose is important because that's the data on which we have the benefit-risk ratio. And that's the data that we have in terms of determining which treatment to use. Using the lower dose of the same drug may not give you all the health benefits. And I'll come to that in a second to show you some example. So which one to use? So the first thing to remember is that there is a dose response between the impact of the drug, GLP-1 receptor agonist in particular, and their pharmacological effect. So DPP-4 inhibitors double your GLP-1 levels. So what do you get with doubling the GLP-1 levels? You get a bit of HbA1c reduction, and you get no weight loss usually with DPP-4 inhibitors. GLP-1 receptor agonists give you more GLP-1. So you get more HbA1c reduction, and you get weight loss. But when you go up and use the weight loss doses of GLP-1, then you get really much more serious weight loss. And interestingly, you don't get any more HbA1c reduction. So the HbA1c reduction doesn't actually go up from here to here, but the weight loss does. And I'll show you examples of that. So that's the liraglutide dose. This is the weight loss dose. That's what gives you the 7.8 or 8% weight loss that on average you see in the clinical trial. The lower doses also give you weight losses, but far less weight losses. So using the 1.8 milligrams to treat obesity rather than 3 will not be appropriate because that's not where the efficacy is. The efficacy comes from the 3 milligrams for weight loss. And if we look at the change in HbA1c in people who take liraglutide 3 milligrams and compare it to the 1.8, then you can see that the HbA1c difference is extremely small in the clinical trial. So increasing the dose from 1.8 to 3 milligrams resulted in greater weight gain, but not necessarily greater HbA1c benefit. So you need to know what you are treating in the patient to give them the right dose of the right drug. Similar data comes from semaglutide. It's clear that semaglutide 2.4 milligrams result in a greater weight loss compared to semaglutide 1 milligram. Both of them greater than placebo. But the 2.4 milligrams that give you greater weight loss compared to 1 milligram and placebo. But when it comes to HbA1c, they are identical. The 1 milligram and 2.4 has similar HbA1c lowering efficacy. So when it comes to treating diabetes, you don't need to go from the 1 to 2.4 if your aim is to lower the HbA1c. The 1 milligram is the right dose. When it comes to treating weight loss, then the 1 milligram may not give you actually the maximum efficacy. You either need to use the approved dose of 2.4, which as far as I understand is not available yet in Pakistan, or you need to use the approved dose of Saxenda or liraglutide of 3 milligrams to really get the health benefit or guarantee getting the health benefits you are expecting. So just a couple of slides about the dosing, just as a reminder, as we are coming towards the end. With Saxenda, you titrate from 0.6 and you add 0.6 all the way till you reach 3 milligrams on weekly basis. With semaglutide, or sorry, with Ozempic, 1 milligram, you start at 0.25, then you double it to 0.5, then you double it to 1 milligram. So I'm going to give you two patients just to highlight those two concepts which we said. So the first patient is Dawood, who is a 48-year-old man. He has type 2 diabetes for 2 years. The HbA1c is 7.8%. The BMI is 27, currently taking metformin, and there is a family history of type 2 diabetes and cardiovascular disease. What are the treatment priorities here? And I'm not testing your knowledge, and because I'm coming towards the end, I will say. So, is it more here about managing the obesity, or is it about managing the HbA1c?
HbA1c.
And what about the CVD as well? So, which dose and drug give us the right combination of effects? Great effects on HbA1c with the CVOT data from people with type 2 diabetes. For that, that would be Ozempic 1 milligram. I'll still get some weight loss effects, which is good, but Ozempic would be the right choice. On the other hand, Kieran, 45-year-old lady, BMI 33, PCOS, and family history of cardiovascular disease. So again, where is the priority here? The BMI is a priority, the PCOS is a priority, the fact that she has cardiovascular disease is a priority. Which drugs will give me the best benefit on these domains? In this case, it's Saxenda. So, in conclusion, when choosing between Ozempic and Saxenda, until you get the 2.4 later, I hope you get it at some point, But at least for now, choosing between 1 milligram semaglutide or Ozempic and 3 milligrams of liraglutide Saxenda. Ozempic should be used for glycemic management in people with type 2 diabetes because that's what it has got the evidence for that dose. And semaglutide 2.4 milligrams should be reserved for weight management, but we don't have it yet here. Saxenda should be used because that's what the evidence for both health benefits. So this is because the weight loss efficacy is dose dependent. So it's important to get the right dose to the right patient. And the benefits of health observed in RCT are at a particular dose. So giving the lower dose may not give you the health benefits. Using semaglutide 1 milligram for weight management is not, in my view, appropriate because it's not the most effective dose for this disease. The effective dose is 2.4. And we don't know what the health benefits of 1 milligram in people with obesity and without diabetes. We have evidence for diabetes, but not without diabetes. And with that, I'll say thank you very much for listening. Stay or go down? Thank you.
Thank you, Professor Dr. Abdurrani, for a very enlightening session and especially highlighting the dosage of GLP-1 and the effects that it produces accordingly. Now, before opening up the floor for Q&As, I would like to take few expert comments from the expert panelists that have joined us in our session today. So I will start with the powerhouse of experience, Professor Dr. Fatma Jawad, a consultant endocrinologist having 22 years of experience in the field of endocrinology. So if you can hand over the mic to Professor Dr. Fatma Jawad for her comments on today's session and in general about GLP-1s.
Thank you very much. It was very enlightening talk experience today. Yes, we have GLP-1 with us for quite some time in Pakistan, and we have been using it, but it's rather not very frequently because, I mean, we all know it's the price factor which is the most important consideration for the patients. So, we don't have a very free hand, I should say, but definitely for whichever patients we have used, we've had good results. Thank you.
Thank you so much, ma'am. Next, we move on to Professor Dr. Shabinaz Masood, a consultant gynecologist, now practicing at Medicare Hospital.
Thank you, Dr. Lee. Regarding Saxenda, I have some experience using it. The only problem that I face is increasing the dosage, because that causes too much of GI symptoms and nausea, vomiting. I don't know what to do. Usually, I have hardly ever exceeded 1.2 milligrams. I start with 0.6 and 1.2. And patients, they do lose weight, but increasing the dosage then causes GI. That is